When encountered with an adrenal incidentaloma in the CT abdomen, the clinician's primary task is to distinguish a benign lipid-rich adenoma from everything else, including lipid-poor adenomas, pheochromocytomas, and adrenocortical carcinomas. In CT, the gold standard is the adrenal protocol, which is a first-line diagnostic tool. In non-contrast CT, a 10 Hounsfield unit threshold is given. If a mass or a homogeneous tissue has an attenuation of less than 10 Hounsfield units, it's classified as repeat-rich adenoma with near 100% specificity. No further imaging follow-up is required for these lesions if they are less than 4 cm and non-functional. Contrast washout CT. If the non-contrast HU was more than 10, we use a washout behavior. Benign adenomas tend to take up contrast quickly and wash it out rapidly, whereas malignancies and pheochromocytoma retain the contrast longer. Absolute percentage washout requires pre-contrast, 60-second enhanced and 15-minute delayed images. A more than 60% retention is diagnostic of an adenoma. Relative percentage washout is another parameter used. If it is more than 40% is diagnostic of an adenoma. MRI is typically reserved for patients who cannot tolerate CT contrast or has characterizing the mass. Chemical shift imaging. This is the most critical MRI sequence that detects signal dropout and out of phase images compared to in phase. The mechanism is intracellular fat and water protons cancel each other. So a drop in signal intensity, often appearing as a mass turning black, confirms a lipid-rich adenoma. While pheochromocytoma has a light bulb sign, often appear extremely bright hyperintense on T2-weighted images, although this is not 100% pathognomonic. Now let's see the common patterns and their diagnostic keys. In a myelolipoma, presence of microscopic fat is there, so it has very low Hounsfield unit of -30 to -120. A pheochromocytoma is highly vascular, often has more than 20 Hounsfield unit on non-contrast and may show salt and pepper on an MRI. An adrenal carcinoma has a larger size of more than 4 cm, irregular borders and invasion of local invasion with hemorrhage and necrosis. Adrenal cyst has less than 10 Hounsfield. Adrenal hemorrhage has more than 30 to 40 Hounsfield units, with that decrease over time as it liquefies. Now coming to size, it matters. Size of more than 4 cm are generally considered suspicious for malignancy and often warrant surgical consideration even if it is non-functional. A growth of more than 5 mm or more than 20% over the next 6 months to 1 year is a red flag of malignancy. Always never ever do a biopsy without ruling out a pheochromocytoma, because that can land up in a pheochromocytoma crisis or hypertensive crisis. So if you are planning biopsy, do it only after ruling out pheochromocytoma.